Good evening, everyone. Please let me know if I am audible and visible, and then we will start with the session. Okay. Thank you. So I will now start with the session. So this is welcome to this FMG Spotlight, where we will be discussing the must-know topics in ophthalmology before you proceed to the exam on the 20th. So we will be discussing the things that are like must know before the exam as far as ophthal is concerned, right? So first what I will do is I will begin with the must know ophthalmology images. So let's have a look at this. So this is, what is the name of this image? What is this image? Who will tell me? This is one of the vision charts, correct? So this is one of our vision charts. So which vision chart is this? Which vision chart is this? Yes, this is the Snellen's chart. So this is our Snellen's chart. So what are the important things that you must know about the Snellen's chart? The Snellen's chart, this is read from a distance of, the Snellen's chart, this chart is to be read from a distance of 6 meters, right? So this chart is to be read from a distance of 6 meters or 20 feet. This is to be read from a distance of 6 meters or 20 feet. If a patient is reading only the first line of this chart, then we annote the visual acuity as 6 by 60. If the person is reading the second line, then we annote it as 6 by 36. If the person is reading the third line, we denote it as 6 by 24. Fourth line, 6 by 18. Then comes 6 by 12. Then 6 by 9 and then 6 by 6. And this 6 by 6 is also written as 20 by 20. And this is your normal visual acuity, right? So from here, what is important to remember, what do we mean by 6 by 60? This is often asked, that 6 by 60 means that this letter is large enough to be seen by a normal person from a distance of 60 meters. This is very, very important. So the same for 6 by 36, 6 by 24, etc. So if we are asked that what is the distance from which a normal person or a person with normal visual acuity will read the 6 by 24 line, the answer is 24 meters. So what is the importance of the denominator? The denominator denotes the distance from which a normal person will be able to read this letter. So 6 by 60 means that a normal person reads this letter from a distance of 60 meters. A normal person reads this letter from a distance of 60 meters. Okay, so please remember these important facts about the Snellen's chart. So this is what kind of chart? This is a visual acuity chart, right? Now what is the name of the other important visual acuity chart? It is this one. So identify this chart for me. What is this chart? This is also a visual acuity chart, right? This is also a visual acuity chart, but how is it different from the Snellen's chart? How is it different from the Snellen's chart? This is also a visual acuity chart only. But how is it different from the Snellen's chart? The difference is that in the Snellen's chart, as you go down, the number of letters in each line, it is increased. So that is how you differentiate from the images of these two charts. Okay. So in the first chart, see, the visual acuity chart, that is the Snellen's chart, the size of the letters is progressively decreasing and the number of letters is also increasing. So the first line has 1 letter, second line has 2 letters, third line has 3 letters, and so on. But here in this chart, the number of letters in each line is the same. So it is a different chart. The number of letters in each line is the same. So now tell me, what is the name of this chart? Correct. This is called as the ETDRS chart. This is called as the ETDRS chart. What is the full form of ETDRS? The full form of ETDRS is Early Treatment Diabetic Retinopathy Study Chart. Early Treatment Diabetic Retinopathy Study Chart, ETDRS chart, Early Treatment Diabetic Retinopathy Study Chart. It was used in this study and hence the name. So this is also a visual acuity chart, but the difference is here the number of letters in each line is the same. So both these we need to know. These are the two important visual acuity. Right, it's also called as the Bailey and Lovey chart, correct? So this is also called as the Bailey and Lovey chart. And what is the distance from which you have to read this chart? This is to be read from a distance of 4 meters. This is read from a distance of 4 meters. Remember this. Okay, now let me show you the next important visual acuity chart, that is this one. So what is the name of this chart and what is it used for? So here see, the size of the letters is the same. The letters are all same in size. They are not decreasing, but it is the brightness of the letters which is decreasing. So this is a test for evaluating what? This is a test for evaluating, correct. This is a test for evaluating contrast sensitivity. This is a contrast sensitivity chart. It is used for evaluating contrast sensitivity. This is a contrast sensitivity chart and the name of this chart is Pelly-Robson chart. The name of this chart is Pelly-Robson chart. Very, very good. So it's a contrast sensitivity chart. It is called as Pelly-Robson chart. And to remember, see, it is the size of the letters remains the same, only the brightness is decreasing. And the distance from which this chart is to be read is, it is to be read from a distance of 1 meter. It is to be read from a distance of 1 meter. Okay, now the last of these charts. Look at this chart. What is the name of this chart? I think everybody knows the name of this chart. This is the color vision chart. This is used for evaluating color vision. As you can understand, see, you can see multiple colors in this chart and the name of this chart is Ishihara chart. Correct. This is called as the Ishihara chart and generally it is to be read from a standard reading distance. The standard reading distance is how much? The standard reading distance is 33 to 40 centimeters. It is read from a distance of 33 to 40 centimeters and as I have told you before also, we have to remember that the Ishihara chart helps us to identify what kind of color deficiency. It is not useful for screening all kinds of color deficiencies. It is used for screening red-green color deficiency. Good. It is used for screening red-green color deficiency. Okay, so these are our important vision charts. So 4 charts, Snellen's charts, ETDRS chart, Pelly-Robson chart and Ishihara chart for color vision. Right, shall we move to the next one? So these are must know. Now look at this. This has come many times, likely to come again. So what is the name of this instrument? The most basic instrument that is used for in ophthalmic OPD. This is called as your slit lamp biomicroscope. This is called as the slit lamp biomicroscope. This is the most basic instrument for evaluation in the ophthalmic OPD and it is important for what? It is meant for essentially for anterior segment evaluation. It is meant for anterior segment evaluation. This is a slit lamp biomicroscope. Now, slit lamp helps us to see the anterior segment, but with the slit lamp, we can also see the posterior segment. But for that, you have to use an additional lens which is kept here. Now, do you remember what is the power of this lens? This lens is called as the 90 diopter lens, correct? So, when you use a slit lamp with a 90D lens, when you use a slit lamp with a 90 diopter lens, you can also evaluate the posterior segment. It also helps us to evaluate the posterior. Okay, so slit lamp biomicroscope is meant for anterior segment evaluation, but slit lamp with 90D we can use for evaluation of the posterior. What are the other instruments for evaluation of the posterior segment? What are the other instruments for evaluation of the posterior segment? We'll come back to that. This is one and this is another. So what are these? What is this? This is again a very, very, very important image. What is the name of this instrument that you see here? What is the name of this instrument? Correct. These are the two ophthalmoscopes. So the first one that you see, this picture, this is correct. This is the DO, that is the direct ophthalmoscope. Very good. So this is the direct ophthalmoscope, and the direct ophthalmoscope, how will you identify it? See, it is the direct ophthalmoscope. It has a handle. On top of the handle there is a roundish head, and if you look at the side, there is a dial here at the side. So this is how you identify the instrument. Now, what are the important things to remember about the direct ophthalmoscope? I hope I'll just quickly run through them. The direct ophthalmoscope, it gives you very high magnification. So what is the magnification of the direct ophthalmoscope? It is around 15 times. So high magnification, that is 15 times, but the view is limited to the central retina, that is the disc and the macula. The view is limited to the central retina, that is the optic disc and the macula. Right? And what kind of image is this? It is a virtual image, and it is an erect image. So virtual and erect image. Okay, so high magnification, but the view is limited to the central retina. The image is a virtual image, and therefore it is an erect image. And here the examiner is getting to use only one eye. The examiner is using only one eye, that is, it is a uniocular instrument, and therefore it doesn't give good perception of depth. So what is this called? This is called as non-stereoscopic view. So it's a uniocular instrument, and therefore it is a non-stereoscopic view. It gives you non-stereoscopic view. Right? So these are the must-know things about the direct ophthalmoscope. Now let's look at the other image. This image, this is the image of the indirect ophthalmoscope. Right? So now this is called as the IDO, or the indirect ophthalmoscope. So how do we use this? We wear the instrument on the head like this, and to focus it we need a lens. So what is the power of the lens? What is the power of the lens that is used with indirect ophthalmoscope? Remember, with the slit lamp we used a lens that was the 90D lens, but with indirect ophthalmoscope the power of the lens that we use, this is a 20D lens. So indirect ophthalmoscope, the power of the lens is a 20D lens. Now what are the important things to remember? The magnification is much lesser than the DO. So the magnification here will be around 2 to 5 times. The mag is around 2 to 5 times, but the view is up to the periphery of the retina. So this is the instrument that is used if you want to evaluate the retinal periphery. So in any question, if you are asked that there is a patient and the pathology suspected is in the peripheral retina, which instrument will you use? The answer is you have to use the indirect ophthalmoscope. Right? And here see the image, this is a real image, and therefore it is an inverted image. So real and inverted image. And two important things to remember, this has a very bright illumination, and because the illumination is very bright, that is why it is useful if the media is hazy. It's a bright illumination, so it is useful if the media is hazy. What do I mean if the media is hazy? Meaning if there is a dense cataract or there is a vitreous hemorrhage. This is useful in that. And last one, it is a binocular instrument, so it gives good perception of depth, which means that the view that you get, this is a stereoscopic view. It's a binocular instrument, so it gives you a stereoscopic view. Okay, so all these points, please quickly recall them. Mag is 2 to 5 times. View is up to the retinal periphery. Real and inverted image. Useful in hazy media because of bright illumination, and it gives a stereoscopic view because it's a binocular instrument. So this has come many times and has got a very high likelihood of coming again. So do revise the differences between the direct and the indirect of. Right? Now, the next image that I'm going to show you is this one. Now, this is an attachment which is attached to the slit lamp. So, what is the name of this? What is this? What is this? I think all of you know this is called as, what is the name of this instrument? What is the name of this instrument? Correct. This is called as the Goldmann applanation tonometer. This is called as the Goldmann applanation tonometer. The Goldmann applanation tonometer, this is, please remember, this is the gold standard of tonometry, or it is the gold standard tonometer. It is the Goldman applanation tonometer, which is the gold standard tonometer. Many times it has come, right? And just to revise, what is this used for? The Goldman applanation tonometer, obviously it is used for evaluation of IOP. It is used for intraocular pressure measurement. And what is the normal range of IOP? Please remember that the normal range of intraocular pressure is 10 to 21 millimeters of mercury. Don't forget this. The normal IOP is 10 to 21 millimeters of mercury. And the gold standard tonometer is this. That is the Goldman applanation. Okay, so these are the must know ophthalmic instruments and their images. So do go through all these. Shall we go to the next image then? Let's go to the next image. Identify this picture for me. A very important clinical condition. What is this? A very important clinical condition. So what do you see? This kind of this whitish lesion which is close to the limbus. What is this? I think all of you know. Very good. This is the Bitort's spot. This is the Bitort's spot. And the Bitort's spot, this is caused by vitamin A deficiency of vitamin A. So this is xerophthalmia stage X1B. So please do remember this stage also, okay? So xerophthalmia stage X1B. This is your Bitort's spot. Very important clinical image caused by deficiency of vitamin A. Okay, now next one. Look at this. What is this? So you can see this kind of a lesion here, a branching lesion like this, and then there are branches like this. What is this? What is this? Again, a very common clinical image which is asked in the exams. You see something like this. Correct. This is a picture of viral keratitis. Very good. So viral keratitis or herpes simplex virus keratitis. This is called as a dendritic ulcer. This is called as a dendritic ulcer. It is caused by herpes simplex virus. So it is also called as HSV keratitis. So it is caused by herpes simplex virus. So it is called as HSV keratitis. Okay, but why is this picture like this? Why is it appearing blue and this lesion that is here, this lesion, why it is appearing green here? What is this? Why is it appearing like this? Because please remember, sometimes they give this picture and they ask that what is the diagnosis? The diagnosis is a dendritic ulcer if it is there in the option, or if HSV keratitis is given in the option, you mark there, or they sometimes ask what is the causative organism for this? The answer is herpes simplex virus. But recently in the NEET PG exam, they gave this same image and they asked that what is the stain that has been used here and what is the filter. So this stain that has been used here is fluorescein stain. It is fluorescein stain or fluorescein dye. And after staining the ulcer with fluorescein stain or fluorescein dye, the filter, that is this blue filter that is used, this is called as the cobalt blue filter of the slit lamp. The cobalt blue filter of the slit lamp that has been put, and that's why you're getting this blue light. So memorize these two also. So this is a picture of dendritic ulcer or HSV keratitis. The dye that has been used or the stain that is used is fluorescein stain, and the blue background is because the cobalt blue filter of the slit lamp has been put on. Okay, another very important must know image. Chalo. Next picture. Have a look at this. Tell me what is the sign and what is the diagnosis. Very important. What is the sign and what is the diagnosis? So what do you see in this picture? You see that when the patient is looking down, the patient has been asked to look down and this protruded cornea is pressing on the lower lid. When the patient has been asked to look down, the protruded cornea presses on the lower lid. This question has come many times in the FMGE paper. Very good. This is called as the Munson's sign. This is called as the Munson's sign. So if we are asked what is the sign is Munson's sign. And if we are asked what is the diagnosis, correct. The diagnosis is keratoconus. The diagnosis is keratoconus. So what is Munson's sign? That is when the patient is asked to look down, this protruded cornea is pressing on the lower lid. And what is the diagnosis? The diagnosis is keratoconus, that is keratoconus. Okay, another very important clinical image. Let's look at the next picture. Have a look at this picture. Again, important clinical image. So you see this kind of a flower shaped opacity in the lens. So you can see that whitish flower shaped opacity like this. What is the name of this opacity and what is it caused by? Both of them can be asked in the exam. So what is the name of this flower shaped opacity? Correct. This is a rosette cataract. This is a rosette cataract and this is caused by blunt trauma. Yeah, I will be discussing the PYQ. I am going to be discuss PYQ after this. After we have a set of images, after I finish this, I will be going to the PYQs. PYQs, of course, are important. So this is a rosette cataract and it is caused by blunt trauma. Okay, again another important image for exam. So let me just go to the next image. Have a look at this. This is also an image exactly from the from the exam paper. A couple of years back it was asked, what is the name of this investigation? All these are must know images from the previous year's papers only. What is the name of this investigation? This investigation is used for evaluation of the retinal vasculature and the name of this investigation is FFA, fundus fluorescein angiography. The name of this image is fundus fluorescein angiography or FFA. So you inject the fluorescein dye into the antecubital vein of the patient and when the dye reaches the retina, we take pictures and this helps us to evaluate the retinal vasculature. So this is an image of FFA. So this has come a few years back. The question was identify this investigation. Then you have to mark FFA or fundus fluorescein angiography as the answer. And if they ask what is this investigation used for, this investigation is mainly used for evaluating the retinal blood vessels or the retinal vasculature. Right? Another important clinical image for example. So, next question. Identify this many times. Must know image. What is this? You see that the whole retina appears to be pale and only the fovea is appearing to be bright red. Tell me what is the name of this image and what is the diagnosis. So the whole retina appears to be pale and it is only the fovea which appears to be bright red. Very good. So this is called as a cherry red spot. So this is the cherry red spot. Now there are, if I say that this cherry red spot, that this is the fundus of a patient, of an elderly 60-year-old patient, that's how the question will be given. This is the fundus of an elderly 60-year-old patient who is a known diabetic. He's presenting with sudden loss of vision. So then what is our diagnosis? If you have cherry red spot in the fundus, elderly patient, history of diabetes, presenting with sudden and severe loss of vision, then the diagnosis is CRAO, that is central retinal artery occlusion. So see, there are other causes of cherry red spot also. So that's why I said that when they give this image, they generally say that this is the fundus picture of an elderly patient, that is 65-year-old patient presenting to us with sudden and severe loss of vision, and this is the fundus. Then the answer is CRAO, central retinal artery occlusion. Okay, another very important question. Now often they have asked what is the management of CRAO. So I am just quickly going to do this here. What is the management of CRAO? So CRAO or central retinal artery occlusion is an ophthalmic emergency. So the management includes, number one is vigorous ocular massage. Vigorous ocular massage. Number two, paracentesis. Paracentesis means aspiration of aqueous from the anterior chamber. Paracentesis or aspiration of aqueous from the anterior chamber. Third, you can give intravenous mannitol with caution. If the patient is hypertensive or he has some cardiac disease, then IV mannitol cannot be given. But if that's not there, you can give. And then inhalation of carbogen. So carbogen inhalation. So vigorous ocular massage, paracentesis or aspiration of aqueous from the anterior chamber, intravenous mannitol, carbogen inhalation. So these are the this is the treatment for CRAO. And please remember, this is an ophthalmic emergency. This is also asked in exam. This is an ophthalmic emergency. Okay, now just like you have told me this, that is CRAO, central retinal artery occlusion. Tell me the next one. Ye jo image hai, this you must know. It has come many times, likely to come again. Look at this one. This also the same thing will be said, that this is the fundus picture of a patient who is a diabetic or a hypertensive, presents with sudden loss of vision. And you see this picture, see the whole retina is full of hemorrhages, multiple red patches throughout the retina. So the whole retina is full of hemorrhages. So ye kya hai? This is correct. This is called as the splashed tomato appearance. Very good. This is called as the splashed tomato appearance. And what is our diagnosis? Splashed tomato appearance, and the diagnosis is correct. This is CRVO, that is central retinal vein occlusion. Central retinal vein occlusion, or CRVO. It has come many times and it is likely to. So cherry red spot, CRAO, splashed tomato appearance. 2 must know images. Abhi next must know image from retina dekho. Have a look at this. If you get this image in the exam, what is the diagnosis you will give? See, this is a very telltale image. Isme dekho, there are like multiple black patches or black pigments in the mid peripheral retina. So these black pigments in the mid peripheral retina, what are they called? They are called as the bony corpuscles or the bony spicules, correct? So these clumps of retinal pigments in the mid periphery of the retina, they are called as the bony corpuscles. And yes, the diagnosis is retinitis pigmentosa. So the diagnosis is retinitis pigmentosa. And what is retinitis pigmentosa? It is a disorder of the rod cells. It is a disorder of the rod cells it is a dystrophy, it is a dystrophy of the rod cells, and so it presents with night blindness, that is nyctalopia. So what is the presenting symptom of retinitis pigmentosa? It is night blindness. And we are often asked, what is the triad of signs? So who will tell me what is the triad of signs? We have to remember these. The triad of signs is, number 1 is waxy disc pallor. The disc is pale, waxy disc pallor. Number 2 is arteriolar attenuation, that is attenuation of the blood vessels. Arteriolar attenuation. And the third one is what you saw in the picture, that is the clumps of retinal pigments, which is called as the bony corpuscles or the bony spicules. So it is a dystrophy of the rod cells of the retina, and because the rod cells are responsible for night vision, therefore, these patients are going to present with night blindness or nyctalopia. The triad of signs is waxy disc pallor, attenuation of the blood vessels, and bony spicules, which is the clumps of retinal pigments that you can see here in the mid periphery. Okay, very important image, and these are the allied things that you must remember from it. Okay, chalo. So these are the must-know images from retina. Now let me show you a few must-know images from neuro-ophthalmology. Have a look at this image and tell me what is this defect called. So I have often told you, whenever you have this image, mark out right, left, and mark out the inner part as nasal and the outer part as temporal. So in this picture, what do we see? We see that the temporal, there is a loss of the temporal field of both the eyes, right? So there is a loss of the temporal field of both the eyes. So isko hum kya bolenge? What are we going to call this? Very good. This is called as bitemporal hemianopia. So this is a picture of bitemporal hemianopia. And if we are given this image and we are asked that what is the site of the lesion, what will we say? Correct. The site of the lesion is the optic chiasma. So the site of the lesion is the optic chiasma. So bitemporal hemianopia, meaning the temporal part or the temporal field of both the eyes are blacked out or they are lost. The temporal field of both the eyes are lost. Bitemporal hemianopia. Site of lesion is the optic chiasma. Abhi next picture dekho, have a look at this. Again, I have told you how to identify. राइट लेफ्ट लिखो, उसके बाद नेजल टेम्पोरल मार्क आउट करो. सो व्हेन यू डू दैट यू रियलाइज दैट द नेजल फील्ड ऑफ वन आई एंड द टेम्पोरल फील्ड ऑफ द अदर आई आर अफेक्टेड. सो द नेजल फील्ड ऑफ वन आई एंड द टेम्पोरल फील्ड ऑफ द अदर आई आर अफेक्टेड. तो इसको हम क्या बोलेंगे? दिस इज कॉल्ड एज होमोनिमस हेमियानोपिया. व्हाट इज दिस कॉल्ड? दिस इज कॉल्ड एज होमोनिमस हेमियानोपिया. And homonymous hemianopia means what is the site of the lesion? Homonymous hemianopia means that the site of the lesion you have to mark out optic tract. So optic tract lesion, it leads to homonymous hemianopia. So optic chiasma lesion leads to bitemporal hemianopia, and optic tract lesion leads to homonymous hemianopia. Now the next one which actually came in the July exam is this. What is this one? Here also see, if I mark out the nasal and the temporal, what will I see? I see that the nasal field of one eye and the temporal field of the other eye are affected. Hai. So the nasal field of this eye and the temporal field of the other eye. So this is also homonymous hemianopia. But see the central area here, this is clear. So this is homonymous hemianopia but with central sparing, also called as macular sparing. So this is called as homonymous hemianopia. This is called as homonymous hemianopia with central sparing or macular sparing. Homonymous hemianopia with central sparing or macular sparing. And if we are asked what is the site of the lesion, the site of the lesion is your occipital cortex. This is the site of the lesion is the occipital. Okay, so these are the few important images from neuro-ophthalmology that can come. So bitemporal hemianopia, homonymous hemianopia with central or macular sparing. Right, now one more field image I'll show you, but this is not from neuro-ophthalmology. Suppose we get this image in the exam. What is this? See, in this image it is something like this. Here the superior half of the field is lost like this. Or you might get an image where the inferior half of the field is lost. So if either the superior half or the inferior half of the field is lost like this, what will we call this? Yes, this is called as an arcuate scotoma. This is an arcuate scotoma. Also called as your Jerem scotoma. So where do you get an arcuate or a Jerem scotoma? This is not related to neuro-ophthalmology. This, an arcuate or a Jerem scotoma, we get this where we get this in glaucoma. This we are going to get, this is the most specific field defect that you get in glaucoma. So either the upper half of the field is lost or the lower half of the field is lost. So this is an arcuate scotoma or Jerem scotoma, and this is seen in glaucoma. This is the most specific field defect that you will get to see. Okay. Now a few other images. Have a look at this. What do you call this? So you can see here, what do you see? You see a swelling on the lid here. And what do you see? You see a pus point here. There is a pus point which is at the base of the eyelash. There is a pus point, a swollen lid, a red swollen lid, and there is a pus point at the base of the eyelash. So what are we going to call this? So if you have an acute infection of the gland which is at the base of the eyelash, no, this is called as a stye. This is a stye, also called as the external hordeolum. This is called as a stye or external hordeolum. And what is the stye or the external hordeolum? It affects which gland mainly? It affects the gland which is located at the base of the eyelash. It is an acute infection of the gland of Zeiss. It is an acute infection of the gland of Zeiss. It's an acute infection. So that's why see it is red in color. Na? So it's a red in color, and you see that there is a pus point at the base of the eyelash, which means that the gland which is there at the base of the eyelash, that is the one which is affected. So this is a stye which is called as the external hordeolum. Now, so this is one acute infection, right? So the eye is red. So the eyelid is red. Now another infection like this where the eyelid is red is this one. This is also acute. But here see, this is your swelling. So this swelling is actually away from the lid margin. So here this maximum tenderness was at the base of the lash, and the pus point was at the base of the lash, that is at the lid margin. This tells us that the gland of Zeiss is probably affected. So it is a stye. But when you have this kind of an acute infection where the swelling is away from the lid margin, so this is an internal hordeolum. This is also an acute infection. But here, which is the gland that is affected? This gland is the meibomian gland. The gland here affected is the meibomian gland. So please remember this. There are two acute infections of the lid glands. The first one is STI, that is external hordeolum, where the gland of Zeiss is affected, and here the pus point will be at the lid margin at the base of the eyelash. But here in case of internal hordeolum, the gland affected is the meibomian gland, so your maximum swelling will be away from the lid margin because the meibomian gland is located in the tarsal plate, which is away from the lid margin. So these two are acute infections, STI, that is external hordeolum, and internal hordeolum. Now one of you was asking me about 𝐒𝐿-𝐈𝐀. See, this is a picture of a 𝐒𝐿-𝐈𝐀. So 𝐒𝐿-𝐈𝐀 is not an acute infection at all. It is chronic. So see, it's not red. It's not at all red. So this is a chronic granulomatous inflammation of the meibomian gland. It is a chronic granulomatous inflammation of which gland? Of the meibomian gland. It's a chronic granulomatous inflammation of the meibomian gland. So see, here also the swelling is away from the lid margin, but it is not red at all and it is painless. So this swelling is going to be a painless lid swelling. Now external internal hordeolum, they are painful lid swellings. This is a painless lid swelling, and remember, it is away from the lid margin. This is away from the lid margin. So these are a few must know things. So this is a 𝐒𝐿-𝐈𝐀. Okay. So this is a chronic inflammation. So that's why see the picture is not red also. So what is the treatment for 𝐒𝐿-𝐈𝐀? This you must know. So there are two treatment options. The first is intralesional steroid injection. So what is the steroid? Triamcinolone. So intralesional steroid injection, that is the first line of management. And if it doesn't improve, then what is the next line? The next line is INC. INC stands for incision and curettage. Incision and curettage. Excuse me. Intralesional steroid injection, incision and curettage. So how do you do this incision and curettage? The incision and curettage requires these two instruments. So see, this is something which has come in the exam. So who will tell me what are the names of these two instruments? These two instruments, they are required for INC of 𝐒𝐿-𝐈𝐀. They are required for the INC, that is incision and curettage. So the first one, what is this? Yes, this has come in the exam. This is called as the 𝐒𝐿-𝐈𝐀 clamp. This is called as the 𝐒𝐿-𝐈𝐀 clamp. And the next one, this is called as your 𝐒𝐿-𝐈𝐀 scoop. The first one is the 𝐒𝐿-𝐈𝐀 clamp, and the second one, this is the 𝐒𝐿-𝐈𝐀 scoop. Okay, so please learn to identify these images. Right. Okay. What is the name? What is the question that you're asking me? That if there is a recurrent 𝐒𝐿-𝐈𝐀, what is the probable cancer? It is sebaceous cell carcinoma. So if you have a recurrent 𝐒𝐿-𝐈𝐀 in an elderly patient, then what is the cancer that you should suspect? If that is the question, then the answer is sebaceous cell carcinoma. Sebaceous cell carcinoma. Okay. Chalo. Next image. Again an image from the exam. So what is this? See, what do you see in the lower lid? You see that the lower lid margin is turned inwards and the lashes are rubbing on the surface of the cornea. So this is an inward turning of the lid margin. This is an inward turning of the lid margin. So what do you call an inward turning of the lid margin? This is called as entropion. This is called as entropion. Entropion means inward turning of the lid margin. So the lower lid margin is turned inwards and therefore the lashes are rubbing on the surface. Now the exact opposite of this is this. So here what do you see? You see that the lid margin is turned outwards, right? So there is an outward turning of the lid margin. There is an outward turning of the lid margin, and the outward turning of the lid margin, what is this called? Outward turning of the lid margin is called as ectropion. This is called as ectropion. Outward turning of the lid margin, this is called as ectropion. Inward turning of the lid margin is entropion, and outward turning of the lid margin is called as ectropion. Okay? Look at this image. See, there are multiple white deposits on the corneal endothelium in this picture. What do you see here? So these multiple white deposits on the corneal endothelium, these are called as the keratic precipitates. These are called as keratic precipitates, right? Or KPs. And what are keratic precipitates? This also has come many times. They are inflammatory deposits on the corneal endothelium. So where do you get inflammatory deposits on corneal endothelium or keratic precipitates? This is seen in anterior uveitis. This is seen in anterior uveitis, also called as iridocyclitis. This is seen in anterior uveitis, also called as iridocyclitis. So these inflammatory deposits or keratic precipitates on the corneal endothelium, they are suggestive of anterior uveitis or iridocyclitis. Okay? Now one last image that we have, look at the shape of the pupil here. When if you have an irregular pupil like this, with what do we call this? What do we call this? If you have this kind of an irregular pupil because of attachment of the iris to the anterior lens capsule, this kind of a pupil, it is called as a festooned pupil. These are called as, this is called as an irregular shaped pupil. This is called as a festooned pupil. Where do we get this? We get this in chronic uveitis. So festooned pupil, which is seen in case of chronic uveitis. Okay, so these are the must know images. I have just put through the images that you must know before you go for the exam. Okay, so now what I'm going to do is I am going to run you through some very important one-liners and the important PYQs so that you have a wrap up of the ophthalmology. Chalo, let's go through the important one-liners and the important PYQs. The first we will have a look through the one-liners. Tell me, what is the epithelium of the cornea? The epithelium of the cornea is cuboidal epithelium, columnar epithelium, stratified squamous, keratinized epithelium, stratified squamous, non-keratinized epithelium. So which is this? What is the epithelium of the cornea? Cuboidal, columnar, stratified squamous, keratinized, stratified squamous, non-keratinized. Correct. The epithelium of the cornea is stratified squamous non-keratinized epithelium. In fact, the epithelium of the cornea or the conjunctiva, whatever you are asked, both of them is stratified squamous non-keratinized epithelium. But in vitamin A deficiency, that is in xerophthalmia. In xerophthalmia, the epithelium, it undergoes metaplasia and it becomes a stratified squamous keratinized epithelium. Okay, so please remember this. These two are very important. So normally the epithelium of the ocular surface, that is conjunctiva and cornea, is stratified squamous non-keratinized. But in xerophthalmia, the epithelium of the ocular surface changes to stratified squamous keratinized. Both these are important, commonly asked questions. Next one. Where do you get to see Horner-Trantas spots? Plictenular conjunctivitis, vernal keratoconjunctivitis, trachoma, adenoviral conjunctivitis. So Horner-Trantas spots are seen where? Correct. Horner-Trantas spots are seen in vernal keratoconjunctivitis, which is also called as spring catarrh. Now, what other things are seen in spring catarrh? Please remember cobblestone papillae or cobblestone appearance. Cobblestone papillae, Horner-Trantas spots, shield ulcer. These three things, they are seen in VKC. So cobblestone papillae, shield ulcer, HT spots, all these are seen in vernal keratoconjunctivitis or spring catarrh. Chalo, next question. Where do you get to see Fleischer's ring? Now, where do you get to see Fleischer's ring? Fleischer's ring, this is a pigmented ring which is caused by, or a pigmented line which is caused by the deposition of iron at the base of the cone in keratoconus. Correct. So, Fleischer's ring, this is a pigmented ring at the base of the cone. Pigmented ring or a pigmented line at the base of the cone. Pigmented ring at the base of the cone caused by iron deposition. Caused by iron deposition, and that is seen in keratoconus. Now, similarly, a pigmented line caused by iron deposition is also seen in pterygium. Does anyone remember what is the name of that line? Pigmented line that is caused by iron deposition, which is seen at the head of the pterygium. This is called as good. This is called as the Stocker's line. Please remember this also. This is also important MCQ. So Fleischer's ring caused by deposition of iron is seen in keratoconus. Stocker's line caused by deposition of iron is seen in pterygium. Again, another two important questions. Chalo, let's go to the next question. What is the refractive error that is seen in keratoconus? So in keratoconus, there is a protrusion of the cornea, of a localized protrusion of the cornea, as a result of which, what is the refractive error that you see in keratoconus? The refractive error that we see is an irregular astigmatism. So you will get an irregular myopic astigmatism, and because of this irregular myopic astigmatism, we are going to get a scissoring reflex on retinoscopy, and this scissoring reflex on retinoscopy is one of the early signs of keratoconus. Both are important MCQs. So what is the refractive error in keratoconus? It is irregular myopic astigmatism, and because of the irregular myopic astigmatism, we tend to get a splitting of the retinoscopy reflex, which is called as the scissoring reflex on retinopathy. Chalo, next question. What is the drug of choice for HSV dendritic ulcer? So HSV dendritic ulcer, we saw an image where you have a linear ulcer with branches. So what is the drug of choice for HSV dendritic ulcer? The drug of choice for HSV dendritic ulcer is, it is topical acyclovir. Please remember, it is topical acyclovir 3% eye ointment. So for HSV dendritic ulcer, the treatment is topical acyclovir, which is given in the form of 3% eye ointment. 3% eye ointment. So for HSV dendritic ulcer, the drug of choice or the treatment of choice is topical acyclovir, which is given in the form of a 3% eye ointment. Don't make a mistake with this, okay? Next question. Phacomorphic glaucoma is caused by. So what is phacomorphic glaucoma? Phacomorphic glaucoma means that there is a swollen lens, and the swollen lens is pushing the iris forward and it is closing the angle. So a swollen lens which pushes the iris forward and closes the angle, that is called as phacomorphic glaucoma, and this is caused by mature intumescent cataract. So mature intumescent cataract, so here we have a swollen lens pushes the iris forward and closes the angle. Swollen lens pushes the iris forward and closes the angle. This is called as phacomorphic glaucoma. Now, where many of you have confused it is with phacolytic glaucoma. Phacolytic glaucoma, this is seen in a hypermature Morgagnonian cataract. So, for hypermature Morgagnonian cataract, it is phacolytic glaucoma. The other name for phacolytic glaucoma is lens protein glaucoma. Here, the lens proteins or the cortex, it leaks out and it blocks the pores of the trabecular meshwork. So here the lens proteins or the lens cortical matter, it leaks out, the liquefied cortex leaks out and blocks the trabecular meshwork. That is called as phacolytic glaucoma. So please remember, phacolytic is for Morgagnonian and phacomorphic is for mature intumescent cataract. So these are again two MCQs. Write it down somewhere and see it before you go for the exam, because they come very commonly and very commonly we tend to get them wrong. Okay, so hypermature Morgagnian is phacolytic and mature and intumescent is phacomorphic. Okay, let's look at this one. Where do you get to see sunflower cataract? Again, very common question. Where do we get to see sunflower cataract? Where do we get to see sunflower cataract? Correct. Sunflower cataract is seen in Wilson's disease. Correct. Sunflower cataract is seen in Wilson's disease. Just to revise the cataracts in the others, see where in diabetes mellitus, what do we get to see? In diabetes mellitus, we will get to see snowflake cataract, right? Snowflake cataract is seen in diabetes mellitus. In galactosemia, we get to see oil droplet cataract. Galactosemia, we get to see oil droplet cataract. And in myotonic dystrophy, we are going to see Christmas tree cataract. Christmas tree cataract. So sunflower cataract in Wilson's disease, galactosemia, oil droplet cataract, myotonic dystrophy, Christmas tree cataract, and Wilson's disease, sunflower cataract. snowflake in diabetes, oil droplet, galactosemia, Christmas tree, myotonic, sunflower cataract, Wilson's disease. Okay, must know questions. Next one, where do we get to see posterior lenticonus? Now, posterior lenticonus, please remember, this is seen where? It is seen in Lowey's syndrome. So, Lowey's syndrome, we get to see posterior lenticonus. And an Alport syndrome, we commonly get to see anterior lenticonus. So, we can remember it as A for A, anterior lenticonus, Alport's, and posterior lenticonus, Lowey's syndrome. Anterior lenticonus Alport's, posterior lenticonus, Lowey's syndrome, anterior lenticonus in Alport. Okay, next one. Where do we get to see sauce and cheese retinopathy? Now, what is the other name for sauce and cheese retinopathy? Sauce and cheese retinopathy is also called as pizza pie retinopathy. So, sometimes instead of giving sauce and cheese, they can give pizza pie also. So, sauce and cheese retinopathy or pizza pie retinopathy, where is it? Where do we get to see? Correct. It is seen in cytomegalovirus retinitis. So sauce and cheese, because there are multiple patches of white and multiple patches of red. So sauce and cheese. So areas, white patches, red patches. So sauce and cheese and pizza pie retinopathy. And the drug of choice is what? The drug of choice is ganciclovir if it is to be given intravitreally. And if it is to be given orally, then valganciclovir. Okay, so if it is to be given intravitreally, it is ganciclovir, and if it is to be given orally, then valganciclovir. This is the treatment for cytomegalovirus retinitis. This also has been asked in recently one of the exams. So sauce and cheese retinopathy, pizza pie retinopathy, seen in CMV retinitis. Where do we have CMV retinitis? CMV retinitis is seen in pain AIDS patients with very low CD4 counts. Treatment intravitreal ganciclovir or orally valganciclovir. Right? Next. Okay. Recurrent anterior uveitis with low back pain in a patient who is HLA-B27 positive. So where do we see what are the pointers in this question? There the patient is HLA-B27 positive and there is a recurrent anterior uveitis. Patient has got recurrent anterior uveitis in a patient who is HLA-B27. Sometimes they mention that this is also a young male patient. Recurrent anterior uveitis, low back pain in a patient who is HLA-B27 positive and young male patient. Correct. So it is ankylosing spondylitis. Ankylosing spondylitis, it involves, you all know, it involves the sacroiliac joint. It involves the sacroiliac joint. Okay, next. What is the drug of choice for uveitis? What is the drug of choice for uveitis? So uveitis is obviously an inflammation. Yes, the drug of choice for uveitis, no, it is not atropine, it is steroid. The drug of choice for uveitis is steroids because see, it's an inflammation. So the drug of choice always has to be steroid. The route of administration of the steroid will change according to the severity and the type of uveitis. So it can either be topical steroid, it can be periocular steroid, it can be systemic steroid. So the route of administration of the steroid will change according to the type and severity of uveitis. But the drug of choice is steroids. Now some of you always, I see some students, they mark atropine as the answer. Atropine is an adjuvant. It is an adjuvant because it is not going to improve the uveitis. What it will do, it is a cycloplegic and therefore it is used to relieve the pain. This is meant for pain relief. This is an adjuvant that is meant for pain relief. So drug of choice for uveitis is atropine. Atropine is an drug of choice for uveitis is steroids. Do not make a mistake of this. Uveitis, the drug of choice is steroids because steroid is actually going to improve the course of the uveitis. But why do we give atropine? Atropine is an adjuvant. It is a cycloplegic and it helps to relieve the pain. So it helps to relieve the ciliary spasm and it is meant for pain relief. Okay, next question. Where do you get to see Dahlen-Fuchs nodules? Where do you get to see Dahlen-Fuchs nodules? So Dahlen-Fuchs nodules, they are typically seen in which condition? Correct. They are seen in sympathetic ophthalmitis. So what is sympathetic ophthalmitis? Sympathetic ophthalmitis means that there is a severe trauma to one eye, as a result of which a severe uveitis develops in the other eye. That is called as sympathetic ophthalmia. So in sympathetic ophthalmia, you get to see these nodules which are called as your Dahlen-Fuchs nodules. Okay, so sympathetic ophthalmia, they ask that which type of trauma causes sympathetic ophthalmia. So please remember that sympathetic ophthalmia is caused when there is a penetrating trauma to the area of the ciliary body. Penetrating trauma to the area of the ciliary body, this can result in sympathetic ophthalmia, meaning there is a severe injury in one eye and this results in severe uveitis in the other eye. Severe injury in one eye results in severe uveitis in the other eye. And what kind of uveitis is this? This is a bilateral granulomatous panuveitis. What kind of uveitis is this? This is a bilateral granulomatous panuveitis. Okay, let's go to the next one. Where do you get to see 100-day glaucoma? Where do you get to see 100-day glaucoma? Where do you get to see 100-day glaucoma? Chalo, tell me. Again, very important question. 100-day glaucoma is a type of neovascular glaucoma that is seen after a period of about 3 months in cases of, correct, it is seen in CRVO, central retinal vein occlusion. So this is a type of neovascular glaucoma that is seen after a period of around 3 months in untreated cases of ischemic CRVO, central retinal vein occlusion. Okay, this is called as 100-day glaucoma. Next question. Where is cattle track sign seen? Where do we get to see cattle track sign? So remember, cattle track sign and cherry red spot, these two things, cattle track sign, cherry red spot, these, if it is there in the question, then the answer is CRAO, central retinal artery occlusion. Central retinal artery occlusion. Okay, cattle track sign. And CRVO, I just told you what is CRVO. CRVO is splashed tomato appearance. So splashed tomato appearance, and another name for this splashed tomato appearance which has been asked a couple of times in some exams is blood and thunder appearance. Splashed tomato appearance, also in some books they call it as blood and thunder appearance. So cattle track sign, cherry red spot, mark CRAO. Splashed tomato appearance, blood and thunder appearance, CRVO, central retinal vein occlusion. Okay, next one. Let's go to the next question. Tell me, where do we get to see HARP striae? This question, something related to this question has come this year in the INI-CET. Where do we get to see HARP striae? Where do we get to see HARP striae? Quickly. Students always make a mistake with this. Remember, HARP striae are seen in ophthalmos or congenital glaucoma. HARP striae are seen in ophthalmos or congenital glaucoma. Okay, so what are these HARP striae? They are stretch lines or striae in which layer of the cornea? They are striae on the descemet's membrane. They are striae on the descemet's membrane and they are horizontal in direction. Remember it as H for H. So they are striae on the descemet's membrane and they are horizontal in direction. They are HARP striae which are seen in ophthalmos or congenital glaucoma. Now, where you have confused it with keratoconus is, in keratoconus, the striae that you see, now they are called as your Vogt striae. So, they are called as Vogt striae. They are also striae on the descemet's membrane, but they are vertical in direction. So, remember it as V for V and H for H. So, HARP striae, horizontal striae on the descemet's membrane, seen in ophthalmos or congenital glaucoma. Vogt striae, vertical striae on the descemet's membrane, which are seen in keratoconus. Okay, chalo, next question. Where do we get to see polychromatic luster? So polychromatic luster and another thing is breadcrumb appearance. Polychromatic luster and breadcrumb appearance of the cataract. Where is this seen? Breadcrumb appearance or polychromatic Cluster, correct. This is seen in complicated cataracts. That is cataracts which are caused by other ocular diseases like chronic uveitis. Okay, so polychromatic luster and breadcrumb appearance, they are typically described in complicated cataract. That is cataract caused by other ocular diseases like uveitis. And what is the typical type of complicated cataract? Please remember, complicated cataract is a posterior subcapsular cataract. This also comes in the exam. So complicated cataract is a type of posterior subcapsule. Next, what is the most common cause of unilateral proptosis in children, or what is the most common cause of proptosis in children? The most common cause of proptosis in children is, very important question, the most common cause of proptosis in children is orbital cellulitis. Very good. So the most common cause of proptosis in children is orbital cellulitis. But if the question is what is the most common cause of unilateral or bilateral proptosis in adult? What is the most common cause of unilateral or bilateral proptosis in an adult patient? The most common cause of unilateral or bilateral proptosis in an adult patient is thyroid ophthalmopathy. Okay, so most common cause of proptosis in a child is orbital cellulitis. Most common cause of proptosis, whether it is unilateral or bilateral in an adult patient, is thyroid. Okay, next. Most common intraorbital tumor in an adult. So most common intraorbital tumor or most common benign intraorbital tumor in an adult patient. So the most common benign intraorbital tumor in an adult patient is cavernous hemangioma. Mind you, here we are not talking about ocular, we are talking about orbital tumors and orbital malignancies. So most common intraorbital tumor, that is a benign intraorbital tumor in an adult patient, is cavernous hemangioma. Now I'll just tell you a few other one-liners here. The most common benign intraorbital tumor in a child is a dermoid. The most common benign intraorbital tumor in a child. Okay, so the most common benign intraorbital tumor in an adult is cavernous hemangioma. Most common benign intraorbital tumor in a child is dermoid. Most common intraorbital malignancy in a child. Most common intraorbital malignancy in a child is rhabdomyosarcoma. And most common intraorbital malignancy in an adult is lymphoma. The most common intraorbital malignancy in an adult is lymphoma. Okay, so please memorize these. Excuse me. Okay, so I'll just go over this once more. Most common benign intraorbital tumor in a child is dermoid. Most common benign intraorbital tumor in an adult is cavernous hemangioma. Most common intraorbital malignancy in a child is rhabdomyosarcoma. And most common orbital malignancy in an adult is lymphoma. Okay, so learn up these 4 one-liners. See, something like this came in the last exam also. So there's a possibility they can ask something like this in this exam also. Look at the next question. Most common intraocular malignancy in children. Which is the most common intraocular malignancy in children? The most common intraocular malignancy in children obviously is correct. It is retinoblastoma. There is absolutely no confusion in that. The most common intraocular malignancy in children is retinoblastoma. But the question that came last time was, what is the most common intraocular malignancy in adults? So the most common intraocular malignancy in adults is choroidal metastases. It is choroidal metastases. The most common intraocular malignancy in adults is choroidal metastases. But here, if they add one more word, that is most common primary intraocular malignancy in adults. If the question says most common primary intraocular malignancy in adults, then the answer is choroidal melanoma. Okay, so then the answer is choroidal melanoma. Okay, so these three questions, please learn them up. Most common intraocular malignancy in children is retinoblastoma. Most common intraocular malignancy in adults is a secondary malignancy, that is choroidal mets. But if the word primary is added to the question, that is what is the most common primary intraocular malignancy in adults, then the answer is going to be choroidal melanoma. Okay, again another set of important one-liners. Please memorize all of them. Okay, let's go to the next question. Yeah, we discussed kiya. Tell me, what is a STI? It is an acute infection of which gland? The STI is an acute infection of gland of Zeiss, meibomian gland, or is it a chronic inflammation of the gland of Zeiss or a chronic inflammation of the meibomian gland? Correct. STI, which is also called as your external hordeolum. STI, which is also called as your external hordeolum, is an acute infection of the gland of Zeiss. An acute infection of the meibomian gland, I just told you, it is internal hordeolum. Acute infection of the meibomian gland, this is also called as internal hordeolum. And chronic granulomatous inflammation of the meibomian gland, this is your chalazion. This is your chalazion. Okay, so two acute infections. Acute infection of the gland of Zeiss is STI, that is external hordeolum. Acute infection of the meibomian gland is internal hordeolum, and a chronic granulomatous inflammation of the meibomian gland. Right? Next one. Most common site of obstruction in congenital dacryocystitis. So congenital dacryocystitis, also called as congenital NLD block. Congenital dacryocystitis or congenital NLD block. What is the site of obstruction? The site of obstruction is correct. It is the valve of Hassner. The valve of Hassner, where is it located? It is located at the junction of the NLD with the inferior meatus of the nose. So the nasolacrimal duct, it opens into the inferior meatus of the nose, and at the junction of this NLD with the inferior meatus of the nose is the valve of Hassner. And the most common site of obstruction in congenital dacryocystitis is the valve of. Now, what is the treatment for congenital dacryocystitis? The treatment for congenital dacryocystitis is sac massage, right? If the child does not improve with sac massage, then you go for probing. Probing is usually done at around 1 year of age. Usually done if the child has not improved up to 1 year of age. Right? And if the child is symptomatic even up to 3 years of age, then you go for surgery. The name of the surgery is DCR, that is dacryocystorhinostomy. And this is usually done after the child is 3 years of age. So after the child year is greater than or equal to 3 years of age, then only you should go for DCR surgery, that is dacryocystosis. So sac massage, that is the first line, that is Krigler's massage. Probing, that is if the child remains symptomatic up to 1 year of age, and DCR surgery to be considered if the child is symptomatic up to 3 years of age. Congenital dacryocystitis. All these we must know very, very well. It has been asked umpteen number of times, high probability of being asked again. Okay? Next question. What is the primary function of the SO, superior oblique muscle? So remember that for the obliques, the primary function is always torsion, rotatory movement. And remember it as sin. Sin means superiors are intorters. Sin, that is superiors are intorters. Superiors are intorters. So the main function of the superior oblique muscle is intorsion. It is intorsion. And the primary function of the inferior oblique muscle is extorsion. The primary function of the inferior oblique muscle is extorsion. So if we are asked, what is the primary function of SO? It is intorsion. What is the primary function of the IO? It is extorsion. But this is for the obliques, because I told you the primary function of the obliques is rotatory movement, that is torsion. But if we are asked superior rectus and inferior rectus, what intorsion, extortion, उनका primary function नहीं है. So for superior rectus, the primary function is going to be elevation. And for inferior rectus, the primary function is going to be depression. So for superior rectus, it is elevation. For inferior rectus, it is depression. For superior oblique, it is intorsion. And for inferior oblique, it is extorsion. Okay, so please remember this. Always remember, for the oblique muscles, the primary function is rotatory, that is torsion. So SO के लिए intorsion, IO के लिए extorsion. But rectus muscles का primary function is not rotatory. So for superior rectus, primary function is elevation, and for inferior rectus, primary function is depression. Okay, chalo, next one. The posterior limit of the orbital floor is formed by the posterior limit of the orbital floor. So please remember, the posterior limit of the orbital floor is formed by the palatine bone. So only for the floor, the posterior limit is formed by the palatine bone. And the posterior limit of the other three walls, the posterior limit of other three orbital walls, that is the roof, the medial wall and the lateral wall, they are all formed by the sphenoid bone. They are all formed by the sphenoid bone. So the posterior limit of the roof, the medial wall and the lateral wall is the sphenoid bone. Only the posterior limit of the floor is formed by the palatine bone. This also again is a commonly asked question where we commonly get wrong. So please remember, the posterior limit of the roof, the medial wall and the lateral wall is the sphenoid bone. Only for the floor, the posterior limit is not the sphenoid bone, it is the palatine. Okay? Next question. Microaneurysms are seen in which layer of the retina? Chalo, this you have to know. This I expect you to answer. Chalo, batao. Microaneurysms are seen in which layer of the retina? Microaneurysms are seen in, correct, microaneurysms, very good, are seen in the inner nuclear layer. So quickly revise, in the inner nuclear layer, what are the two things we see? In the inner nuclear layer, we get to see microaneurysms and we will get to see dot blot hemorrhages. So inner nuclear layer, you get to see microaneurysms and dot blot hemorrhages. What do we get to see in the nerve fiber layer? What do we get to see in the nerve fiber layer? Nerve fiber layer में we get to see flame shaped hemorrhages. So nerve fiber layer में we get to see flame shaped hemorrhages and we get to see cotton wool spots. So cotton wool spots and flame shaped hemorrhages, they are seen in your nerve fiber layer. And in the outer plexiform layer, where what do we get to see in outer plexiform layer? In the outer plexiform layer, we will get to see hard exudates. So this slide you must know like the back of your hand. This has been asked many times and can be asked again. So in the inner nuclear layer, two important things to remember: microaneurysm, dot blot hemorrhages. Nerve fiber layer, flame shaped hemorrhages, cotton wool spots. Outer plexiform layer, we get to see hard exudates. Okay, chalo. Next, the nerve fiber layer of the retina contains what? What does the nerve fiber layer of the retina contain? Chalo, quickly. What does the nerve fiber layer of the retina contain? Correct. The nerve fiber layer of the retina, it contains the axons of the ganglion cells. So the axons of the ganglion cells, they form the nerve fiber layer of the retina, and this nerve fiber layer of the retina, it eventually becomes the optic nerve. So if you are asked in the exam, what is the optic nerve made up of? So the optic nerve is also made up of the axons of the ganglion cells only. So the axons of the ganglion cells are going to form the nerve fiber layer of the retina, and the nerve fiber layer of the retina eventually forms the optic nerve. So the nerve fiber layer of the retina and the optic nerve, they are both formed by the axons of the ganglion cells. Okay, now where do we find the cell bodies of the photoreceptors? The cell bodies of the photoreceptors, they are seen in the outer nuclear layer. Memorize these also. Cell bodies of the photoreceptors are seen in the outer nuclear layer of the retina. Cell bodies of the bipolar cells are seen in the inner nuclear layer of the retina. And the cell bodies of the ganglion cells, this is easy, they are seen in the ganglion cell layer of the retina. They are seen in the ganglion cell layer of the retina. So cell bodies of the photoreceptors in the outer nuclear layer, or ONL, cell bodies of the bipolar cells in the inner nuclear layer, and cell bodies of the ganglion cells in the GCL, and the axons of the ganglion cells in the nerve fiber layer of the retina, which eventually becomes the optic nerve. Okay, next question. Where do we get to see bony corpuscles? Abhi discuss kiya. I think everybody remembers this. Where do we get to see bony corpuscles or bony spicules? Where do we get to see bony corpuscles or bony spicules? Correct. This is hallmark of retinitis pigmentosa. So bony corpuscles are seen in retinitis pigmentosa. In Stargardt's disease, we get beaten bronze appearance of the macula. So if you are asked, where do you get beaten bronze appearance of macula? Beaten bronze appearance of macula is seen in Stargardt's disease. And in Best's disease, we get to see egg yolk appearance of the macula. So beaten bronze appearance of the macula in Stargardt's disease, egg yolk appearance of macula in Best's disease, and bony corpuscles are seen in retinitis pigmentosa. All these are different types of retinal dystrophies. They are all different types of retinal dystrophy. Okay? What is the most common presenting feature of retinoblastoma? Retinoblastoma we just discussed. It is the most common intraocular malignancy in children. It is the most common intraocular malignancy in children. And what is the most common presenting feature of retinoblastoma? Correct. Leukocoria, that is white pupillary reflex. Leukocoria or white pupillary reflex. This is the most common presenting feature of retinoblastoma. Right now, the gene that is meant for retinoblastoma, you all know it is the RB gene. Do you remember what is the location of this? What is the location of the RB gene? It is, you all know it's a tumor suppressor gene. And what is the location of the RB gene? The location of the RB gene is 13q14, correct. So the location is 13q14. Please remember this. And what is the most common second malignancy associated with retinoblastoma? The most common second malignancy that is associated with retinoblastoma, the most common second malignancy associated with retinoblastoma is osteosarcoma. So the most common second malignancy that is seen in survivors of retinoblastoma, that is osteosarcoma. And what is the most common route of spread of retinoblastoma? What is the most common route of spread of retinoblastoma? The most common route of spread of retinoblastoma is direct spread via the optic nerve. The most common route of spread of retinoblastoma is direct spread via the optic nerve. So these are also some other important questions. Please memorize them. Okay? So these are important things to be known about R. Next. Now, sphincter pupillae muscle originates from. So, which germ layer do the iris muscles? Not just the sphincter pupillae, both the dilator pupillae and the sphincter pupillae. So, the dilator pupillae and the sphincter pupillae, they originate from which germ layer? We know that there are 4 germ layers now, which give rise to the different ocular structures. That is neuroectoderm, surface ectoderm, mesoderm, and neural crest cell. So, the sphincter pupillae and the dilator pupillae, they originate from the neuroectoderm. The neuroectoderm. Okay. Now I'll just tell you the important questions that are asked from the embryology. So see, neuroectoderm, this gives origin to the optic nerve, the layers of the retina, and remember it gives origin to the iris muscles. These are the ones that are asked. Optic nerve, retina, iris muscles, which is sphincter pupillae as well as dilator pupillae. In सब का origin जो है, that is from neuroectoderm. सरफेस एक्टोडर्म से जो ओरिजिनेट करते हैं उसमें से इंपॉर्टेंट स्ट्रक्चर्स आर द क्रिस्टलाइन लेंस, then the epithelium of the cornea and conjunctiva. The epithelium of cornea conjunctiva. They originate from the surface ectoderm. Mesoderm, the important derivatives are sclera and extraocular muscles. Sclera and extraocular muscles. And neural crest came out of the important derivatives. Remember the angle of the anterior chamber. This is a derivative of the neural crest cell. There are others also, but these are the must know for the exam. So see, neuroectoderm, optic nerve, retina, iris muscles. Surface ectoderm, lens, corneal epithelium. Mesoderm, sclera, extraocular muscles, neural crest cells, angle of anterior chamber. ये जो है, these are the commonly asked ones in the exam, so memorize this for the last one. ठीक है? Next, what is the drug of choice for acute angle closure glaucoma? So for acute angle closure glaucoma, what is the drug of choice? Now the drug of choice, please remember, it is pilocarpine. Why it is pilocarpine? Because it constricts the pupil and breaks the acute attack. It constricts the pupil and breaks the acute attack. That is why it is the drug of choice. But it is not the first drug to be administered, because this pilocarpine cannot act if the pressure is very high. So IV mannitol, this is the first drug to be administered. First drug to be administered is mannitol, but the drug of choice is actually pilocarpine. The mannitol is only going to temporarily reduce the IOP so that the pilocarpine can start acting. So the drug that is actually affecting, as actually helping us to break the attack, is pilocarpine, because it constricts the pupil. But because it cannot act when the pressure is very high, so that's why the first drug to be given is intravenous. ये भी दो slightly confusing questions है जो बहुत बार पूछा. Okay, chalo, let's go to the next question. Where do we get to see Lish nodules? So Lish nodules, these are like small roundish lesions which are seen in the iris, and they are typically seen in NF1, neurofibromatosis 1. इसको भी याद कर लो, commonly asked one-liner. Lish nodules, they are typically seen in NF1. They are like nodular lesions which are seen in the iris. Okay, so these are the one-liners which I thought that we must discuss before you go for the exam. Now let me go to the important PYQs. So chalo, I think we'll have to, all of you must have done the important PYQs. This is just to go through it once more. A child who has a history of malnutrition, that is actually the key word in the question. He has a history of malnutrition and the following finding is noted. What is the diagnosis here? The child has a history of malnutrition and this is noted. What is the diagnosis? Correct. The diagnosis, this is anterior staphyloma, or sometimes they can give xerophthalmia also in the options. So they will either give anterior staphyloma or xerophthalmia in the option. This is caused by deficiency, obviously, of vitamin A. So vitamin A deficiency. So xerophthalmia or anterior staphyloma caused by vitamin A deficiency. So the key, the crux of the question is that this is a child who has a history of malnutrition. So that is what leads us to the answer. Okay, chalo. Next question dekho. A 7-year-old child is diagnosed with amblyopia in one eye. Instead of amblyopia, they can also give lazy eye. So what is the treatment of amblyopia or lazy eye? Observation, penalization, occlusion, or none of the above? Correct. It is occlusion. Now occlusion of which eye? Occlusion of the normal eye or the good eye. So you have to occlude the good eye or the normal eye so that the child is forced to use the other eye, and that will help in the treatment of lazy eye or amblyopia. Okay, so occlusion of the good or the normal eye, that is the treatment of lazy eye or amblyopia. Chalo. What is the treatment of choice for recurrent pterygium? The treatment of choice for recurrent pterygium. The treatment of choice for recurrent pterygium is excision with conjunctival autograft, that is CAG. It is CAG. It is not treatment with mitomycin C. This question lot of students have asked me many times. See, the drug that is, if the question says what is the drug used for the treatment of recurrent pterygium, then the answer is mitomycin C. But mitomycin C has its own complications. So it is not the most commonly used method. The most commonly used method is the surgical method, that is excision with conjunctival autograft. So whether they ask treatment of choice or they ask best method or they ask what is the most preferred method or they ask what is the most commonly used method, kuch bhi पूछें, the answer is conjunctival autograft. Okay, so treatment of choice, best method, most preferred method, most commonly used method is excision with autograft. Only if they ask what is the drug that is used in the treatment of recurrent pterygium, then our answer is going to be mitomycin. Okay, chalo, next question. A patient presents with loss of vision, pain on eye movements. RAPD, that is relative afferent pupillary defect is seen, and on perimetry there is a central scotoma. तो यहाँ पे key words क्या है? There is a sudden loss of vision, there is pain on eye movements, right? And see, they are seeing RAPD is seen. RAPD is seen का क्या मतलब है? RAPD means that the optic nerve is involved. RAPD means that the optic nerve is involved, and it also is showing central scotoma. So central scotoma is also seen when there is optic neuritis. So this is our okay. So a patient presents with sudden loss of vision, there is pain on eye movements, RAPD is seen, and there is a central scotoma. So the answer is optic neuritis. Now इसको बच्चे हमेशा confuse करते हैं with papilledema. Please remember, in papilledema there will be no loss of vision. The patient sorry, I should not say it like that. In papilledema, the patient does not present with loss of vision. The complaint of the patient is not loss of vision. The complaint of the patient is going to be headache with projectile vomiting because of raised intracranial pressure. Headache with projectile vomiting. Why? Because of raised ICT, raised intracranial pressure. So that is the presentation of the patient. The patient may have transient vision loss, that is called as amaurosis fugax. Amaurosis fugax. So transient vision loss or amaurosis fugax may be present, but patient जो complaint लेके आएगा, that is not loss of vision. The patient is going to be a very sick patient whose complaint is severe headache with extreme vomiting because of the raised ICT. He may also have an associated complaint of transient vision loss, which is called as amaurosis fugax. But देखो इस question में कैसे, what does this question say? This question says the complaint of the patient is vision loss, and there is a pain which is associated with movements of the eye. There is RAPD which suggests involvement of the optic nerve, and there is a central scotoma to corroborate it. So all this suggests that the diagnosis is optic neuritis. Okay, very important question. Next, this question all of you will know, but it's a very important question. A patient presents with history of trauma with vegetative matter, and there is pain and photophobia. So देखो, history of trauma with vegetative matter is the keyword in the question. So what is our diagnosis? What kind of corneal ulcer is associated with trauma with vegetative matter? Correct, it is fungal keratitis. तो और क्या क्या keywords इस question में हो सकते हैं which we should look for or which may be there? So the other keywords that may be present is multiple lesions or satellite lesions. Multiple lesions or satellite lesions, and the question might say that the margins are feathery. Satellite lesions, feathery margins, trauma with vegetative matter. These are the keywords if they are present in the question. Na? So we have to mark fungal keratitis as the. Okay? Next question. A patient has a BCVA which is more than 1/60 but less than 3/60. What type of blindness does he have? So basically, BCVA in the better eye is less than 3/60. So BCVA in the better eye less than 3/60 means what kind of blindness it is? It is social blindness. Correct. Social blindness is BCVA in the better eye less than 3/60. BCVA in the better eye less than 6/60 is economic blindness, and less than 1/60 this is manifest blindness. So BCVA in the better eye less than 6/60 economic blindness, less than 3/60 will be social blindness, less than 1/60 this is manifest. Okay, again important question. And BCVA less than 6/18 in the better eye, this is low vision. Less than 6/18, that is low vision. Chalo. A lady presents with ptosis, and on movement of the jaw, that is on eating and sipping fluid, the ptosis decreases, which means that whenever there is a movement of the jaw, the lid also moves up and down. So there is a fluctuation of the ptosis with movements of the jaw. What is this called as? This is called as complicated ptosis. So complicated ptosis इसमें option में है तो वो mark करना है. But instead of complicated ptosis, sometimes they may have this in the option, which is called as Marcus Gunn jaw winking syndrome. Marcus Gunn jaw winking syndrome. So this is the other name for this. So if they have complicated ptosis तो उसको mark करो. अगर Marcus Gunn है option में तो उसको mark करो. So basically this means that this is a complicated type of ptosis where there is a fluctuation of the ptosis when there is a movement of the jaw. So if you move the jaw, the lid also moves up and down. Why? Because there is an abnormal communication between the third and the fifth nerves. An abnormal connection between the third and the fifth nerves. This is Marcus gun jaw winking. Okay? Next question. Repeat question multiple times आया है. Newborn baby or neonate presenting with watering photophobia. So the triad of this condition is watering photophobia and blepharospasm. Watering photophobia and blepharospasm, and this is the clinical picture. See, you have large eyes and the cornea is so hazy it is almost appearing to be bluish in color. So newborn baby presenting with the triad of symptoms: lacrimation, that is watering, photophobia and blepharospasm. On examination, large eyes with extremely hazy cornea which is almost appearing blue in color. So this is ophthalmus, that is congenital glaucoma. So this is ophthalmus or congenital glaucoma. Ophthalmus or congenital. Ophthalmos or congenital glaucoma. Okay, next question. On looking through a pinhole, the visual acuity of a patient improves. What is the diagnosis? So if when you look through the pinhole, if the visual acuity improves, meaning suppose a patient's visual acuity was 6/36 and after putting a pinhole it becomes 6/6. So it is improving with pinhole suggests what? Correct. If it is improving with a pinhole, it suggests a refractive error. This is suggestive of a refractive error. But suppose there is a patient's visual acuity which is 6/36 and with pinhole also it remains 6/36. Then this suggests some kind of ocular pathology. This suggests that there is some ocular pathology, that is, it may be anything. It may be a cataract, a retinal pathology, corneal opacity, anything. But it suggests that there is no component of refractive error. So if on looking through a pinhole the visual acuity of a patient is improving, then this is suggestive of a refractive error. That is our answer. Okay. Chalo. Let's look at the next question. A factory worker suffers trauma to the anterior part of the eye with iron foreign body. So it is a metallic foreign body. So if it is a metallic foreign body, what is the investigation that you will do? This is not even an ophthal question also. So what is the investigation to be done if it is a metallic foreign body? If it is a metallic foreign body, you have to do a CT scan. If it is a metallic foreign body, you have to do a CT scan. And for a metallic foreign body, absolutely contraindicated will be an MRI. So this is very, very important, okay? So if you have an ocular trauma with a metallic foreign body, you will suggest for a CT scan. And absolutely contraindicated for a metallic foreign body is an MRI. If it is a non-metallic foreign body, then you suggest an MRI. If it is a non-metallic foreign body, like for example, if it is a wooden foreign body, if it is a non-metallic foreign body, then you suggest an MRI. So metallic foreign body suggests CT scan, MRI is contraindicated. Non-metallic foreign body, you suggest a magnetic resonance. This MRI. Okay, chalo, next one. Very, very common question. 1.5-year-old child presenting with the following clinical picture. So what is the clinical picture? What is this? This is a white pupillary reflex, right? So white pupillary reflex means leukocoria. White pupillary reflex or leukocoria. So what is this? Retinoblastoma, right? So this is retinoblastoma. So see, they are saying it's a 1.5-year-old child. The commonest age of presentation of retinoblastoma is around 1.5 years, that is 18 months. Presents with white pupillary reflex or leukocoria, and see, look at the USG feature. It shows a mass with intraocular calcification. So these are the pointers or the keywords in the question. Child is 1.5 years old, presents with white pupillary reflex, USG shows a mass with calcification. So these three things, they point to a diagnosis of retinopathy. Okay, this we have already discussed. A tumor in the anterior pituitary. So tumor in the anterior pituitary causes what? It causes pressure over the optic chiasma. So if there is a pressure in the optic chiasma, lesion of the optic chiasma causes what kind of defect? We discussed it when we were doing the images. Correct, it causes bitemporal hemianopia. So tumor in anterior pituitary which compresses the optic chiasma. So any lesion which affects the optic chiasma is likely to cause bitemporal hemianopia. Next, a patient presents with miosis, anhidrosis and slight drooping of the upper lid, which means a mild ptosis. So these are what? These are the features of what? So what are the three features? Mild ptosis, miosis, anhidrosis. So mild ptosis, miosis, anhidrosis means Horner syndrome, also called as oculosympathetic palsy. Also called as oculosympathetic palsy. So meiosis, mild ptosis, anhidrosis. These are the features of Horner syndrome, also called as oculosympathetic palsy. Collagen cross-linking is used in the treatment of which disease? So corneal collagen cross-linking with riboflavin, C3R. Corneal collagen cross-linking with riboflavin, this is the treatment for which condition? Which of these conditions? Correct, it is used in the treatment of keratoconus. It is used in the treatment of keratoconus. So in keratoconus, the first line of management is rigid gas permeable contact lenses or RGP lenses. So the first line of management is rigid gas permeable contact lens. You try to improve the vision of the patient with contact lens. If the patient doesn't improve, you can go for C3R. And the last option is keratoplasty, that is cornea transplantation. These are the important treatment options for keratoconus: RGP lens, C3R, keratoplasty. Okay? Next question. What is the most common ocular presentation in patients of COVID-19? Not just COVID-19, for most of the upper respiratory tract infections also. If you have a patient who has an upper respiratory tract infection, the ocular presentation may be what? It is it's not actually conjunctiva, it is actually follicular conjunctivitis. Follicular conjunctivitis. Follicular conjunctivitis. So the most common ocular presentation is follicular conjunctivitis. What is the most common ocular presentation in patients of Marfan syndrome? What is the most common ocular presentation in patients of Marfan syndrome? So the most common ocular presentation in patients of Marfan syndrome is correct. It is subluxation of the lens. So what is the position of the lens in Marfan syndrome? It is superotemporal. So superotemporal subluxation of the lens. This is the most common ocular presentation of Marfan. And if I ask you what is the position of the lens in homocystinuria, there also you have subluxation. It is inferonasal. So please remember these two. Inferonasal. Okay, so most common ocular presentation in Marfan is subluxation of the lens, where it will be superotemporal. In homocystinuria also there will be subluxation of the lens, but here the position of the lens is usually inferonasal, which is exactly the opposite of Marfan. Right? Next one. Which is the laser that is used in laser assisted cataract surgery? Which is the laser used in laser assisted cataract surgery? So laser assisted cataract surgery में कौन सा है? This is called as FLACS, femtosecond laser assisted cataract surgery. So the answer is C, femtosecond laser assisted cataract. So just to quickly revise, which lasers are used where in ophthalmology? So where is femtosecond laser used? Femtosecond laser is used in smile surgery. What is smile surgery? Smile surgery is a type of refractive surgery. It is a type of refractive surgery, and femtolaser is used in FLACS. What is FLACS? FLACS stands for femtolaser assisted cataract surgery. Femtolaser assisted cataract surgery. Cataract surgery. Femtolaser assisted cataract surgery or FLACS. So smile surgery, which is a type of refractive surgery, and FLACS, which is a type of cataract surgery. Both of them, they are done with femtolaser. Now, where do we use excimer laser? Excimer laser is used for LASIK. LASIK is a type, again, it's the most commonly done refractive surgery. So excimer laser is used in LASIK and ND-YAG laser. Where do we use ND-YAG laser? ND-YAG laser. Where do we use ND-YAG laser? ND-YAG laser, this is used for laser peripheral iridotomy, that is laser PI, which is done in angle closure glaucoma, and it is used for laser capsulotomy, which is done for after cataract or PCO, posterior capsule opacification. So where are we going to use these lasers? Just quickly running you through them. Excimer laser is used for LASIK, which is the most commonly done refractive surgery. Femtosecond laser has two applications: smile surgery, which is an advanced form of refractive surgery, and flax, which is an advanced form of cataract surgery. ND-YAG laser is used for laser peripheral iridotomy or laser PI, which is done in angle closure glaucoma. And it is also used for laser capsulotomy, which is done for PCO or after cataract, that is posterior capsule opacification or after cataract. Okay, so these are the important lasers in ophthalmology. इसको भी अच्छे से याद कर लो. This is also something which has got a high chance of being asked. Chalo. What is the test that is used here? I think everybody will be able to tell this. What is the test that is used here? The name of this test is Shermer's test. The name of this test is Shermer's test, and this is a test for what? This is a test for dry eye. So you have this strip that is kept here in the lower fornix, and you see how much of this strip becomes wet at the end of 5 minutes. So this strip is placed in the lower fornix at the junction of the medial 2/3 and the lateral 1/3, and the patient is asked to sit in normal temperature. The AC and the fan are put off, and after 5 minutes you try to see how much this strip is wet. So what is normal? Normal is if there is more than 15 mm. Greater than 15 mm of wetting is considered to be normal. Borderline is 10 to 15 mm. So if there is 10 to 15 mm of wetting, that is called as 10 to 15 mm of wetting. This is called as borderline. And diagnosis of dry eye is if the wetting is less than 10 mm. If the wetting is less than 10 mm, then that is considered to be dry eye. And if the wetting is less than 5 mm, that is considered to be severe dry eye. So more than 15 is normal, 10 to 15 is borderline, less than 10 is dry eye, less than 5 is severe dry eye. Okay, so this is your Shermer's test, most commonly done test for dry eye. Next. A 65-year-old patient who has a history of cataract surgery 1 year back. So his surgery is already done. Now he is complaining of diminished vision, and what do you see? You see that behind the lens, the posterior capsule is opaque, right? So what is this? This is called as PCO, that is posterior capsule opacification. So the posterior capsule, which is behind the IOL, has become opaque, and that is why the vision has gone down again. So this is called as PCO. The old name for this condition is after cataract. So please remember, this is the most common late complication, meaning it's going to happen months or sometimes years after cataract surgery. So most common late complication of cataract surgery. Most common late complication of cataract surgery. So the patient has already undergone a cataract surgery. Months or years after that, he is coming back with complaint of decreased vision, and you see this kind of a whitish layer which is behind the IOL. So this is PCO, posterior capsule opacification, or after cataract. And what is the treatment? The treatment is to create a cruciate opening at the center of the posterior capsule with the help of laser. And what is that called? I just discussed. That is called as laser capsulotomy. So the treatment for PCO or posterior capsule opacification is laser capsulotomy, and we just discussed it is done with ND-YAG laser. So laser capsulotomy done with ND-YAG laser, that is the treatment for this condition. Again, another very commonly asked, commonly repeated question. Okay, next. What is this instrument used to assess? Now this instrument, this is used to evaluate the corneal curvature. So this instrument, this is used to evaluate the curvature of the cornea, and you see these rings that are there, they will help to evaluate if there is a localized abnormality in the corneal curvature, if there is an overall abnormality in the corneal curvature. All these are used, can be picked up by this instrument. This is used to evaluate the corneal curvature. This is also an image which has come recently, I think couple of years back it was there in your FMGE. Okay. According to the WHO classification of xerophthalmia, what is stage X2? According to the WHO classification, what is stage X2? So who will tell me what is stage X2? Correct. Stage X2 is corneal xerosis. This is stage X2. Night blindness, you all know this is XN. Conjunctival xerosis is X1A. And Bitot spot is X1B. So night blindness is XN, conjunctival xerosis is X1A, Bitot spot is X1B, corneal xerosis is X2. Now see, night blindness, this is the earliest symptom. So this is the earliest symptom, that is night blindness. Okay, conjunctival xerosis, this is the earliest sign. This is the earliest sign. And Bitot spot, this is the most specific sign. This is the most specific sign. So earliest symptom is night blindness, earliest sign is conjunctival xerosis, Bitot spot is the most specific sign. And xerophthalmia is reversible up to stage X2, that is corneal xerosis. So up to the stage of X2, it is reversible. Once it becomes X3, X3 is the stage of corneal ulceration. After that, it is not reversible. Even if it heals, there will be a formation of a scar. Okay, so earliest is XN, which is the night blindness earliest symptom. Then X1A, conjunctival xerosis, is your earliest sign. But the most specific sign is Bitot spot, that is stage X1B. And the corneal involvement begins in stage X2, that is corneal xerosis. And X3 is the stage of, what is stage X3? X3 is the stage of corneal ulceration or keratomalacia. It is corneal ulceration or keratomalacia, that is X3. So, xerophthalmia, it is reversible up to the stage X2. That is, up to the stage of corneal xerosis, it is reversible. Once it is ulceration, it is not reversible. It will heal, but even if it heals, there will be formation of a scar, and that will lead to loss of vision. Right? So, this is your WHO classification of xerophthalmia. This also you have to remember very, very well. Next. What is the cause of acute hemorrhagic conjunctivitis? Acute hemorrhagic conjunctivitis, this is caused by three important viruses. We remember it as ACE. A stands for obviously adenovirus. C stands for 𝐒𝐿 virus. It stands for 𝐒𝐿 virus. E stands for enterovirus and ecovirus. Adenovirus, 𝐒𝐿 virus, enterovirus and ecovirus. So here see, actually adenovirus and enterovirus are both correct, but adenovirus is far more common. So that's why we have to mark adenovirus as the answer. So cause of acute hemorrhagic conjunctivitis, we will mark adenovirus as the. Okay, so these are the questions that I wanted to discuss with you. I have tried to just compile the important one-liners, the important PYQs and the important images, so that you will have a run-through of the important topics in Ophthal just before your exam. So I hope that this session has been useful for all of you, and all the very best for the exam. And before I sign off, I will just tell you a couple of things or a couple of tips for the exam. So see, you have all prepared very well. So be confident of your preparation. Stay calm during the exam. And just 2-3 things which you should do or should not do. Number one, today is like Sunday and you have hardly a week left for the exam. So first thing that you have to do in the remaining days is regularize your sleep cycle. So see, as medicos, we have this tendency of sleeping late and getting up late, right? So you might be studying up to 3 a.m. and then you may be getting up at 11 a.m. But remember, the exam is going to be during the daytime. So you want your brain to be sharpest during that period. You don't want your brain to be dull in the examination hall. And if you want to do that for these few days before the exam, regularize your sleep cycle. You sleep at night and you study during the day, so that on the exam day your brain will be sharp during the exam hours. Don't go to the exam with a brain which is like dull during the exam hours. So regularize your sleep cycle from today onwards. Sleep at a normal time. Sleep by about 9:30, 10 o'clock, maximum by 11 o'clock, and get up at a normal times. Get up by 8:39 and start your day. So sleep at night, study in the day for the next few days. Now, what are the things you have to be careful about in the exam? Number one, read the questions very, very carefully before marking the answer, because in the stress of the exam, you often tend to ignore words. Like, for example, you tend to ignore words like all except or not. All these are true about keratoconus except, or which of the following is not true about keratoconus. So when we are stressed out and we are trying to read the paper, now we tend to miss out these words. You tend to miss out except, you tend to miss out not, and that is going to, and you will lose that question unnecessarily. So read the question carefully. Don't miss words like not and except. Third important thing is that read all the four options before you mark the answer. Read all the four options before you mark the answer, because see, don't be trigger happy and mark the first one as the answer, because sometimes there may be two options which are like very close. That may be option A and option D. So unless you read up to option D, you will not realize that there was another option which was close. Okay, so don't mark without reading all the four options. Even if you feel you know the answer, read all the four options and then choose the most appropriate. Right? Next thing is, see, during the exam, pacing of the exam is very, very important. So pace the exam properly, meaning, see, when you look at the question, our stress levels are very, very high. And when your stress levels are high, you tend to underperform. That is normal. It happens to everybody. So what you have to do is you have to calm down your brain. Now this is more easily said than done. So what I have done in all my exams and what I advise students to do is that in the first go, don't waste your time on questions where you have a confusion. You run through the questions and mark in the first go the questions which you know. There will be a large percentage of questions which will be direct, indirect repeats. There will be either a direct repeat question or an indirect repeat. So in the first go, now you mark those questions. जिसको पढ़ते ही you know the answer. So and when you read and you feel that नहीं इसको मुझे सोचना है, मुझे नहीं पता, उसको first go में mark मत करो. You go to the next question. So ऐसे in the first 1 hour or so, what happens is in the first, say not 1 hour, maybe in the first 30-35 minutes, you find that मैंने इतने सारे question जो है ना उनको अच्छे से कर लिया है. Now when you feel that, your brain automatically calms down. कि हाँ इतने सारे क्वेश्चन तो मुझे आते हैं, मैंने कर लिया है. So then your brain calms down and then you start functioning better. This used to happen to me. I have done my exams like this and I tell students to do it this way because it worked for me. Initially बहुत high होता है. So that's why if you try to think in that situation of stress, your brain will not function well. But once you know that हाँ so many questions easy थे, मैंने उनको ठीक से कर लिया है, your brain will automatically calm down. You will start functioning. Right? And the last is, this is something that I have gathered by talking to students. Usually the first instinct that you have when you read a question, that is the right answer. So बहुत स्टूडेंट्स ने मुझे बोला है कि फर्स्ट इंस्टिंक्ट में हमने इसको मार्क किया था, फिर ओवर थिंक करके हमने अपने आंसर को चेंज किया और वो गलत हो गया. So don't overthink. Usually ना वो instinct, वो gut feeling correct होता है. That gut feeling doesn't come out of nowhere. It comes out of what you have studied over the past so many months or. So most students have told me this, that वो gut feeling पे जो mark करते हैं वो सही होता है, फिर उसको overthink करके हम change कर देते हैं. I would advise, not that all questions are like that, but I would advise you not to overthink. What you feel is the answer usually is the answer. Right? So all the very, very best for the exams. Stay calm during the exam. Be confident of your preparation and do not give up till the last question is done. So your focus, your concentration has to remain till the last question is. Okay? All the very, very best. I'm sure you'll all do well. All the best. Bye-bye.